Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone. I am Virani, and I am a professor of cardiology as well as a preventive cardiologist. I had the pleasure to serve as the chair for the 2023 American Heart Association, American College of Cardiology Guideline on the Management of Chronic Coronary Disease.
And I'm Kristen Newby. I'm a professor of medicine in the Division of Cardiology and a faculty member of the Duke Clinical Research Institute at Duke University School of Medicine. And I served as the co-chair for the Chronic Coronary Disease Guidelines.
So this is our third and final podcast episode discussing the major takeaways from the Chronic Coronary Disease Guideline by the American Heart Association, American College of Cardiology. In the first and second episodes, we introduced the guideline. We talked about general approach to treatment. What do we do about the social determinants of health? What does it mean to be patient-centered care that we can provide? What is team-based care? In the second episode, we discussed approach to risk stratification in patients with chronic coronary disease and some of the important recommendations related to lifestyle. In this episode, we'll get into details related to recommendations about statin therapy, weight management, antiplatelet therapy, as well as some considerations related to the use of revascularization in patients with chronic coronary disease. And we'll close out the episode talking about special populations and follow-up management plan in these patients. So let's start out with a very important issue, which is how do we manage lipids in these patients? So Christian, you want to give us some guidance on that?
Yeah, let's jump right in. We know that statins are the first line of defense and the first line in therapy of lipid-lowering agents for patients with coronary disease. So we do, although we know that and we've known that now for years, we have some important updates to the guidelines, and we'll go over those here in the next couple of minutes. So we now have several lipid-lowering therapies that are adjuncts to statin therapy as the first line. Those include ezetimibe, the PCSK9 or proprotein convertase sublysin connexin type 9 inhibitors, bempedoic acid, and inclisiran. Just to mention that for inclisiran, we don't have clinical outcomes data yet, but it is a novel agent that we think has shown some promise and have included it in the discussion in these guidelines. So our class 1 recommendations for statin therapy include high intensity statin therapy with the aim of achieving at least a 50% reduction in LDL cholesterol levels, and that is to reduce the risk of major adverse cardiac events. If high intensity statin therapy is contraindicated or it's not tolerated, we can use moderate intensity statin therapy to achieve a 30 to 49% reduction in LDL cholesterol levels. And then we want to keep emphasizing that lifestyle changes are important, and we should assess diet, exercise, other components that are important in lipid-lowering therapy, as well as the actual effects of our lipid-lowering therapy by measuring fasting lipids in 4 to 12 weeks after we initiate a statin, make a dose adjustment, and then every 3 to 12 months thereafter. So this is both to see the effectiveness, but also to assess compliance with therapy.
So, statins, of course, remain class 1 recommendation. Monitoring of lipids is a class 1 recommendation, as was alluded to, which sometimes is missed that since we don't have particular targets for LDL cholesterol lowering, we don't need to measure lipids, but it's a class 1 recommendation to look at the efficacy of lipid lowering that we perform in these patients, as well as to actually document adherence to lipid lowering therapy. Now, after these class 1 recommendations, we have quite a few class 2 recommendations, and those are mostly related to non-statin therapy use in these patients. So there are some important principles described in this guideline. There is this concept of very high risk ASCVD patients. Now, these are patients who either have major ASCVD events or they have had one ASCVD event but have multiple risk factors. And the reason that we define these patients as very high risk ASCVD and recommend use of non-statin therapies in these patients is because these are the patients who have the highest absolute risk of having a future cardiovascular event. And therefore, these are the patients who will actually derive the most benefit from the use of non-statin lipid lowering therapy. So we have class 2A recommendation for the use of ezetimibe and then PCSK9 inhibitors in a stepwise manner if LDL cholesterol levels remain above 70 or non-HDL cholesterol levels remain above 100 in these very high risk ASCVD patients. So that's very important for clinicians to follow whether these patients are very high risk or not. And if they are they candidates for ezetimibe therapy or PCSK9 inhibitors? Now we have two other non-statin therapies that are now FDA approved. One is bempedoic acid, which recently showed improvement in cardiovascular outcomes in CLEAR Outcomes trial. And this is especially important as a therapeutic option in patients who have statin intolerance. And then, as was mentioned earlier, the last non-statin therapy that was approved is inclisiran, which is an siRNA directed against the messenger RNA for PCSK9. And that is a medication that is undergoing clinical trials right now. And once it undergoes clinical trials, and of course, there will be an update to this guideline, but that also remains an option for patients with CCD, especially since the dosing regimen can be 90 to really 6 months apart, depending on when you're starting out. Initially it's dose on day 0, then after 90 days, and then it's every 6 months. So that is also a consideration for clinicians to use. But right now the use of inclisiran is a class 2B recommendation.
So the next thing we want to touch on is weight management, and we have some important new recommendations on management and treatment in that area. So first of all, if patients are overweight by the BMI assessment, they need to be counseled on dietary and nutritional recommendations. And if you listen to podcast 2, we went into that in detail and why that is so important. But that should be a foundational approach. We do have some new class 1 recommendations. So in patients with type 2 diabetes, the use of either an SGLT2 inhibitor or GLP-1 receptor agonist with proven cardiovascular benefit is recommended. And in patients with chronic coronary disease and heart failure with an EF less than 40, regardless of whether or not they have diabetes, use of an SGLT2 inhibitor is recommended. And these drugs have shown some effectiveness in weight reduction, even at these diabetes and cardiovascular treatment doses. Now, these are not recommendations at weight loss reduction doses. And Dr. Ronnie, I don't know if you want to go into that in more detail.
So I'll provide a very quick overview. So it's extremely important that we measure BMI in all patients who are presenting to our clinics, and in some patients the use of waist circumference may be beneficial as well. Once that's done, patients who have obesity, the first sort of therapy that we have to do is really lifestyle therapy, and we know that works in good number of these patients. So that's a class 1 recommendation. Now, if lifestyle therapy does not work and we have BMI above 30 or BMI between 27 to 29.9, but patients have comorbidities related to obesity, then in those patients, we have the option of using medical therapy. And as we know, recently we've had a lot of data related to GLP-1 receptor agonists. So those could be therapies that could be considered. That's a class 2 recommendation. And there we have some head-to-head comparison between various GLP-1 receptor agonists as well. For example, we know that semaglutide is better than liraglutide in terms of head-to-head comparison. So those are recommendations that are there. Now, we also have a class 2 recommendation for patients who have morbid obesity or those who have BMI of more than 35 up to 39.9 but do not respond with at least a 5% weight loss to medical therapy that we just talked about. In those patients, actually surgery does remain an option. And that's again a class 2 recommendation. So in those patients where we have done lifestyle recommendations, we have done medical therapy, but despite that they have very high BMI or they have medical comorbidities with those BMIs, then in those patients, once these things are done, consideration for bariatric surgery is also there. And we know from observational data that bariatric surgery can actually improve cardiovascular outcomes as well as reduce the burden of these comorbidities. So those are some other considerations related to weight management in these patients. Now, the other important aspect, which sometimes is very complicated when it comes to management of patients, just because there's too much data available, is the use of antiplatelet therapy in patients with chronic coronary disease. So I'll provide you some very uh, general recommendations related to the use of antiplatelet therapy in patients who are not on any anticoagulant. Then Dr. Newby will go over some more recommendations in more details. A general principle is that shorter duration of dual antiplatelet therapy is safe and effective in many circumstances, particularly when the risk of bleeding is high and the ischemic risk is low to moderate. So, with that being said, the approach depends on the type of patient. First, we'll look at recommendations for patients with a CCD and percutaneous coronary intervention. So, in these patients who have CCD and a PCI that was performed, we have a class 1 recommendation to use dual antiplatelet therapy or DAPT, consisting of aspirin and clopidogrel for 6 months post PCI, followed by single antiplatelet therapy. Now, if needed, there is also a class 2 recommendation in these patients if they have a drug-eluting stent and if they have completed 1 to 3 months of DAPT, that one could consider a P2Y12 inhibitor monotherapy for at least 12 months. So that is also an option, especially if we want to reduce bleeding risk. So we can cut down on the duration of DAPT therapy if we believe that bleeding risk is high in our patient. So in patients with CCD and no indication for oral anticoagulant therapy, we also have a class 1 recommendation for low dose aspirin therapy. And that, of course, is recommended in most patients with chronic coronary disease. However, in patients without recent ACS or those who have not had any PCI related indication for DAPT, the addition of clopidogrel to aspirin therapy is not useful to reduce MACE. So I think we should, as clinicians, keep that in mind. And last but not the least, we have a class 3 recommendation, which is a very strong recommendation to avoid NSAID use, at least especially long-term NSAID use in patients with chronic coronary disease, because we know that long-term NSAID use can increase bleeding complication and also increase the risk of cardiovascular events in patients with CCD. So with that, I'll pass it over to Dr. Newby to talk more about antiplatelet therapy and the use of anticoagulants in patients with CCD.
So thanks, Salim. I think this is probably one of the most complicated areas of the guidelines, and I would just remind our viewers that there is an excellent figure in the guidelines that goes into detail on some of the things that Dr. Virani just went through. So it is not straightforward, but I think there's a lot of new information. And I would also highlight that this is an area where both shared decision making and a team-based approach is absolutely critical to coming up with the right duration and type of antiplatelet therapy. I'm going to talk now a little bit about antiplatelet therapy with direct oral anticoagulants, or the non-vitamin K oral anticoagulants. So we have a class 1 recommendation that in patients who have undergone elective percutaneous coronary intervention and who require oral anticoagulant, that we should have dual antiplatelet therapy, or DAPT, for 1 to 2 weeks. That's then followed by clopidogrel alone for 6 months, in addition to that DOAC. We also have a couple of class 2 recommendations that are important, although they have less clear risk benefit than our class 1 recommendation. And that is, in patients who have undergone PCI who require an oral anticoagulant, continuing aspirin in addition to clopidogrel for up to a month is reasonable for patients who have a high thrombotic risk and a low bleeding risk. And again, here's where likely we're going to need a team-based approach to make that type of decision. Further, in patients who need an oral anticoagulant and have a low atherothrombotic risk, we can discontinue aspirin with continuation of the DOAC alone for a year after PCI, and dropping the aspirin is to reduce the bleeding risk. Then there are a couple of other class 2 recommendations to consider. First, in patients on DAPT, use of a proton pump inhibitor, or PPI, can help in reducing gastrointestinal bleeding risk, so has a class 2 recommendation. And if patients have no indication for a DOAC or DAPT and have high risk of recurrent ischemic events and low to moderate bleeding risk, we can add rivaroxaban at a low dose, 2.5 milligrams twice daily, to the aspirin, and that's reasonable for long-term reduction of the risk of MACE.
So again, we hope that you will look at that figure that really simplifies these recommendations in this very rapidly evolving area of the use of both antiplatelets and oral anticoagulant therapy in patients with chronic coronary disease. The other area that's evolved quite a bit since the last chronic coronary disease guidelines were published is basically beta blockers. Now, of course, we know that in patients who have depressed EF with CCD, i.e. EF less than 40%, it's a class 1 recommendation to use beta blocker therapy, especially those beta blockers that have shown benefit with cardiovascular outcomes in these patients. But importantly for clinicians, there are two other recommendations that are extremely important. One is a 2B recommendation to really reassess the need for beta blocker use in patients who are more than 1 year out from their MI. If they don't have an ongoing indication, for example, depressed ejection fraction, continued angina, need to use beta blocker for hypertension control, if they don't have uncontrolled arrhythmias for which a beta blocker is needed, then I think we should reassess the need for a long-term beta blocker therapy. So that's a 2B recommendation. And then we have a class 3 recommendation that really in patients who do not have any prior MI or who don't have depressed EF, beta blockers are not beneficial for reducing MACE in the absence of another primary indication that we talked about, right? MI, continued angina, uncontrolled arrhythmias. So if none of these indications are there, then perhaps the use of beta blocker is not beneficial in those patients. So as we are evaluating pill burden in these patients, which can be a very important consideration, this is one area that we should keep in mind and see if there is a need for continued beta blocker therapy when a patient may be 4 or 5 years out from their MI, does not have depressed EF, does not have ongoing angina. Is there a need to continue beta blocker therapy?
So I'm going to turn a little bit and talk about anti-anginal therapy, which also involves beta blockers. And we have a kind of cornerstone recommendation that either a calcium channel blocker or a beta blocker is recommended as first-line anti-anginal therapy. In addition to that, sublingual nitroglycerin or nitroglycerin spray is recommended for immediate short-term relief of angina or anginal equivalent symptoms. For patients with angina who are symptomatic after treatment with either a calcium channel blocker or a beta blocker as the initial therapy, it's recommended that we can add a second anti-anginal therapy from a different therapeutic class. So if the patient was started on a calcium channel blocker, add a beta blocker. Patient started on a beta blocker, add a calcium channel blocker. We can also consider long-acting nitrates, and ranolazine is recommended for patients who remain symptomatic despite treatment with beta blockers, calcium channel blockers, or long-acting nitrate therapy. We do have a class 3 recommendation for patients with normal LV function to avoid ivabradine as an adjunct to standard anti-anginal therapy, as it's potentially harmful.
So we talked about medical therapy for angina, but we know that revascularization can be an important consideration in patients with chronic coronary disease as well. Now, in one of our earlier podcasts, we talked about the importance of medical therapy. So once that's done, and patients have continued angina that is lifestyle limiting, then revascularization is strongly recommended as a class 1 recommendation, because we know that in patients who do not respond, revascularization does help with angina as well as quality of life. So there are 3 class 1 recommendations in this section that we would like to highlight for our listeners. First, in patients who have significant left main disease or severe LV dysfunction defined as LVEF less than or equal to 35 in this particular recommendation, then we know that coronary artery bypass grafting, in addition to medical therapy, is recommended to improve cardiovascular outcomes. So it's recommended on top of medical therapy. The second class 1 recommendation in this section pertains to the use of heart team approach. So in patients where we have a complex triple vessel disease or for whom the optimal treatment strategy is not clear, a heart team approach is recommended that includes representatives from interventional cardiology as well as cardiac surgery. And last recommendation that we have, which is a class 1 recommendation, is in patients who have angina or anginal equivalents who have not had any previous ischemic evaluation and or angiography, they are found to have intermediate coronary stenosis, then the use of fractional flow reserve, FFR, or other proven non-hyperemic pressure ratios, for example, IFR, is recommended before proceeding with percutaneous coronary intervention. So those are some important considerations in terms of the use of revascularization in patients with chronic coronary disease.
So one of the other things that we have addressed in this guideline is a number of special populations. So we have several recommendations about how to handle these individuals. And these might include patients with HIV or AIDS, cancer, pregnant women, and younger patients with coronary disease. So let me point out a few of those special recommendations. So we'll talk about first patients with chronic coronary disease and chronic kidney disease concurrently. So in that case, we want to take measures to minimize the risk of treatment-related acute kidney injury. Revascularization for patients with moderate to severe ischemic burden can be reserved for patients who remain symptomatic despite medical therapy, so that we don't expose them to contrast and the potential for contrast-induced nephropathy. High-dose statins are potentially helpful in reducing the occurrence of contrast-induced acute kidney injury. If we do send a patient to cardiac catheterization, we want to minimize the risk of contrast nephropathy by avoiding other nephrotoxic agents. We want to ensure adequate prehydration and minimize the volume of contrast media that we use for that case. Radial access may minimize the role of aeroembolism on the development of acute kidney injury. And if we have cath the patient and we can delay bypass surgery for 24 hours after the procedure, we may also reduce the risk of acute kidney injury. We have found no benefit of bicarbonate or N-acetylcysteine over normal saline for prevention of AKI.
Now, another special population that we have in patients with chronic coronary disease are really patients who have undergone heart transplant. So we have recommendations pertaining to cardiac allograft vasculopathy in heart transplant patients as well. And for them, we have 3 recommendations. We have a strong class 1 recommendation for the use of statin therapy in these patients, because we know that the use of statin therapy prevents cardiac allograft vasculopathy in these patients. In addition, we know that there are interactions between a lot of statins as well as medications used to prevent rejection in patients who've undergone cardiac transplant. So there's a table 24, that's out there in the guideline. I would recommend clinicians to look at that table, because that provides practical guidance in terms of how to look at interaction between statin medications as well as the use of medications that are used to prevent rejection of cardiac allograft. Second, there is a class 2A recommendation for the use of aspirin therapy for prevention of allograft vasculopathy in these patients. And we also have a class 2A recommendation for the use of revascularization for patients who may have proximal discrete lesions. We know that in these patients, the use of PCI may be helpful to help with symptoms. And as we all would agree that the use of coronary artery bypass grafting in these patients is associated with very high early mortality. So as much as we can, PCI is preferred over the use of coronary artery bypass grafting in these patients who are symptomatic with discrete lesions where PCI can be performed safely. So those are some recommendations related to cardiac transplant recipients and the management of CCD in these patients.
Now that we've gone over all the updates to the specific treatments that we can use, what we want to talk about now is our approach to follow-up of chronic coronary disease patients. And we have some important recommendations in this area as well. So first of all, for patients with stable CCD, we have a class 2B recommendation. Perhaps not the strongest, but again, worth considering, that it could be beneficial to refer patients to telehealth programs and community-based programs for lifestyle interventions for management of cardiac risk factors. And again, this may be very important after considering patients' access to care, their environment, again, kind of the social determinants of health. We also have an important recommendation for what not to do with stable coronary disease patients. So a class 3 recommendation for patients with no change in clinical or functional status. We state that routine periodic invasive coronary angiography should not be performed. And the reason for this is that it can cause harm. So vascular access complications, kidney injury, and additional complications that are known with angiography in the setting where we know there is no benefit for doing routine invasive evaluation. Similarly, without a change in clinical or functional status with optimized guideline-directed medical therapy, that we have recommendations that routine periodic testing with coronary CTA or stress testing with or without imaging is not recommended. Routine periodic assessment of LV function is not recommended to guide therapeutic decision-making in the absence of some change in clinical or functional status.
So that is it as far as the overview of guidelines is concerned. Now, there's a lot of information here. So we would really recommend that our listeners go back to the guideline, read it as much as you can. But as it is said, guidelines do not implement themselves. It's one thing about guideline writing. It's a totally different thing about implementing those guidelines. Of course, this podcast and other derivative products are created so clinicians can find it useful to implement these guidelines in their practice. So my recommendation for clinicians who are listening to this podcast will be that look at some of the recommendations that you think you can readily implement in your practice, implement those, come back to the guideline again, and see what else you can do. The second thing that I would like to emphasize is that there's a lot of stuff that we all need to do when it comes to management of these patients who are complex patients, who are chronic patients. They are on a lot of medications. There are a lot of other medical issues as well. So again, it becomes extremely important. We talked about it in one of our podcasts to leverage the entire CV team. This is a team sport. One clinician will not be able to fully manage a patient with chronic coronary disease. So we hope that some of these recommendations as well as this guideline will help you in taking care of these patients. But I would also like to ask my colleague, Dr. Newby, to add a few takeaways that she thinks are extremely important for clinicians who are listening to this podcast.
Yeah, so I agree with everything you said. I mean, I think this is a wonderful guideline. It has a lot of great information and a lot of new updates that I think are going to be really important to improving, quality of care outcomes for our CCD population. I think if I had to think about one thing that I think structurally and fundamentally is important to come from these guidelines is how important assessing social determinants of health and taking those into account as we're thinking through the guidelines and how we implement those recommendations to make it possible for all of our patients to get the treatments and risk stratification that we think is important. And then I know you asked me if there was one takeaway, but I would say there's probably the second one is the team-based approach, that we have to do this, and an important critical component of the team is not just the healthcare providers, it's the patient and the patient's family who will be absolutely critical to the implementation and adherence to these guidelines.
So with that, I really thank all our listeners for joining us on this journey of podcast that has really gone through all the major recommendations from the 2023 guideline for the management of chronic coronary disease on behalf of our entire guideline writing committee. Thank you for listening to this podcast, and we hope that this podcast and other derivative products will help you in not just reading this guideline, but actually implementing this guideline in your clinical practice. So thank you for your time, and take care.
The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.